I'd like to welcome everybody to today's webinar where we're going to talk a little bit about MIPS and then we're going to transition over to talking about the managing your patients with prediabetes and undiagnosed hypertension. My name is Scott Mash, and as always I am joined by my good friend Cathy Costello. So we'll start with talking a little bit about the QPP website. Cathy's going to walk you through developing a game plan. We're going to reiterate some of the timelines and then talk a little bit about reporting your quality using any of the approved registries. So we really recommend you always start by going to the QPP website. Now I'm going to give CMS props because they have done a great job with this website, pulling together all of the macro MIPS information. Start by first going to qpp.cms.gov, checking the MPI number for all your physicians, whether you got one, whether you got 100. That way you'll know which physicians are going to be need to report on all parts of the program. Some providers that are deemed hospital-based will be exempt from the ACI measures. Some are going to be exempt from everything. Go there, start, know where your providers are, what you need to do for each of those providers. This website is definitely a great resource for looking up your exclusions. There's good information about group reporting, whether you're using the CMS web interface, doing EHR reporting, or using a registry. Take the time to research your quality measures that you plan to report on. Get the details from the QPP website. Do some further research around the specs for those measures. Advancing care information, of course, they've got all your information there. The improvement activities. Man, there's a ton of improvement activities. Now, what you're going to find here on the QPP website is a very short description and then the improvement activity number. They don't give a lot of depth to the improvement activities. So our recommendation is that you have some real good documentation to support that. Cathy will talk more about that later. And then if you're doing group participation, great information on how you are to pull that information together, how you report as a group. So with that, I'm going to turn it over to Cathy.
Hey, thanks, Scott. Hi, everyone. Thanks for joining us. What we'd really like to do today is to share, as we've gone through this process, we're now entering the last quarter of the year, what I'd call some helpful hints. It's kind of just stuff that we've discovered over the past 6 to 8 months about how to make MIPS reporting easier or to understand the process, because it was not really clear when you looked at the 3,000 pages of regs as to what exactly CMS wanted you to do. So I think it'll help to kind of review it and see, as you enter this last quarter, where you should be with your reporting, if you're going to report, what the analysis should be, and then moving into a discussion about diabetes and hypertension and how you can use what you're doing in your practice to support your MIPS reporting in these two areas. So first of all, many of you have heard us talk about developing a game plan for this year. And I would still encourage you to do this, only you have to update it. We're going into the fourth quarter. It's kind of like the football game is tied, and you've got to figure out what you're going to do to move ahead. So things that are tied to timeline is what we suggest dealing first. The first thing is you want to, as you know, there are 4 areas to MIPS. You don't have to worry about cost. Don't even consider it. You do have to worry about clinical practice improvement. You do have to worry about what used to be called meaningful use, ACI, and you do have to be concerned about your quality reporting. So we're going to look at each one of these areas, but you want to start with clinical practice improvement, mainly because almost every clinical practice improvement activity that you can claim requires you to have been performing it for at least 3 months in 2017. So I am going to guess that the vast majority of practices have already been performing at least 10 to 15 of the activities already. but you just need to document it. And so you want to get that looked at and selected by next week so that you can then demonstrate that you've been doing it for a 3-month period. And as I said, it's not that you're going to be submitting clinical practice improvement activities to CMS. You're merely going to be checking either yes or no that you have done certain activities and that they total up to the number that you want. But the reality is, should you be audited in the future, you're going to want to have that little narrative explaining what you do to earn activity in this area. You want one of those activities to give you bonus points in your technology area, better known as ACI. And we'll talk about that in a minute. But there are 15 specific ones that will give you additional 10% bonus in your ACI, or advancing care information. You can check your ACI. You can then move on with quality to make sure that you are looking at your quality measures. You've selected the 6 that you want to report on, and then select a transmission method. What I'm going to tell you, I'm going to change the order a little bit. I mean, that's what we had developed earlier this year. And the reality is that you're probably going to want to figure out how you're going to report first, because that's going to make some of your reporting easier. And we'll look at that in just a minute. But the first thing you need to look at is to recognize, do you want to report? Do you want all your providers to report? And that may sound kind of simplistic, but the reality is, if you're a rural health center or an FQHC, you're going to have very little dollars that are tied up in potential penalties for non-reporting. So it may be, anything that is covered under your rural health center or FQHC billing is not subject to penalty. And what little you bill outside of that structure is not going to basically impact or be something that you need to worry about. So you want to, if you're a smaller practice, that is something that you want to consider, is whether you want to report at all. If you do want to report and avoid the 4% penalty, recognize that 2017 is like what we call a gimme year, that CMS is giving you the opportunity to do the least possible so that you are getting familiar with the process. And anything that you do, literally anything that you do, you submit one quality measure, you submit one clinical practice improvement activity for a 3-month period, and you will avoid penalty. And the more you report in the 3 areas that you do report on, the more you report, the more points you get. And then that increases your chance of receiving a small or moderate bonus. And so this would be the second thing that I'd suggest is if you do want to report, how much are you going to report? And what I tell people, because it's been a long year for everyone, is don't stress out about it. If you are really stressed, and we've actually given this advice to some of our sites, if you are really stressed and you have only a handful of providers, it may be that you don't want to try to get the whole bonus. All you really have to do is submit one thing and avoid a penalty. And that is about as easy as you can get, and certainly a lot easier than the past few years with PQRS reporting. Another thing that you want to decide early on is whether you want to do group reporting. And this is, you are at the point this year where you should be making that decision, because it will affect how you move ahead for the rest of the year. If you do individual reporting, because this is the first year where you can look at doing individual or group reporting, if you do individual reporting, it may be that you have a number of providers exempting out of the individual reporting. So taking it back to Scott's first couple of slides where he's looking at the QPP website, if you're not sure whether your physicians are eligible, or if you remember a couple months ago, CMS sent these lovely letters out that said blah, 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 blah is eligible, or blah, 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 blah is ineligible and stuff. And although they got directed to the facility, you may not have seen them, and you may not be aware of whether all your providers are going to need to report. So just go to the QPP's website, plug in your NPI, and it's really nice how it comes up, because it tells you if your provider needs to report, if they report as an individual or if they report under your tax ID. It also says whether they are a rural provider, whether they're a hospital-based provider. These are all areas that feed into the amount of reporting that you do. And so do this first. Go there, look at it, see if that provider needs to attest as an individual, or see if you want to do the group reporting. If you do the group reporting, everything smashes down into one set of numbers for everybody in the group. Again, it's a lot easier to do your attestations if you do the group reporting. But what we found, again, you start this year, brand new process, and you're thinking you understand all the ins and outs, and we thought everyone would want to do group reporting, and that's not the reality.
Sure.
I mean, a lot of people are doing individual reporting for different reasons. We have a couple of groups that are well over 100 providers, and at least one that's over 200, that decided to keep their reporting at the individual level. And the reason they did that was for different reasons, but one of them was to reward the practitioners who were performing. And some of it has to do with how your organization, what type of contracts your providers work under. And if they are incentivized for quality, this is one way that you would give them incentive dollars, is to attest at the individual level, and those that perform well will receive higher and maybe even the highest reimbursement for the year.
Yeah, we've got another site that's transitioning to a new EHR, and so some of their providers are probably going to go the route of the exclusion or the exception due to the EHR transition, but some that can. So they're making a concerted effort to report for as many as possible individually. So.
Yeah, so again, everyone's position is different, but just take a deep breath and sit back, talk to the people in your practice, and decide exactly what you're trying to achieve by this reporting. If you're trying to achieve top dollar for everybody, you're trying to reward individually, or you're just trying to get by and avoid penalty. Those are going to produce different ways of reporting. But the other thing that as we've gone through the year, we've discovered new things, and one of the things is that CMS has already changed the reporting for next year. And it's very important. This is an important issue for everyone to recognize. The reason we're saying that is because what is being, and this is no longer proposed, this is a final rule. This particular part of all the regulations is final. Not all the regulations are final, but this is. And what this is saying is that everybody, hospitals and physicians in 2018 do not need to either A, have 2018 technology installed in 2015, which is stage 3 edition technology. They do not have to have it installed at the beginning of 2018. They do not have to attest to stage 3 measures in 2018, and the reporting period is only 90 days. So it's really up to you to decide your own timeline, and gives everyone, including your vendor, breathing room around how you're going to take these upgrades, when you want to pay for them, and what the bottom line is. Because if you decide to report, for example, 3 months at the end of this year on your technology reporting, which is the old meaningful use, and then you decide, well, let's just slide through an additional 3 months at the beginning of 2017 using the same stage 2 standards that you're using this year, you can do 6 months back-to-back reporting and meet your requirements for this year and next on the technology reporting, and then take your stage 3 upgrade. And that will give you a good 6 to 9 months to work on your workflow, do your education around the measures with your providers, get the bugs worked out. As Scott said, we've seen so many problems with reports that I'm all for taking as much time as possible, if you can, in adopting either a new or an upgraded system. So keep that in mind. If you've already decided to take your stage 3 upgrade this year, that is perfectly fine. Now, a lot of you already had it in works before this reg came out. And if you do that, that then allows you the opportunity to decide if you want to use stage 2 measures or you want to use stage 3 and report on later 90 days in the year. That's really up to you and how you're doing with your education.
And we could see some tweaks for 2018 and 2019 because we've got that macro MIPS modification rule and the physician fee-for-service rule, which come out. Should be finalized next month.
This week, this coming week, because CMS is required to get it out. It has a lot of the payment upgrades and everything in it. So we know those rules will be out no later than the beginning of the following week. So less than 2 weeks, but most likely next week. And so you'll have all the final details that you might need going into 2018, but you can take this particular set of measures and data is already final.
Yep.
So we're okay with that. And this is the message. You don't need to upgrade to 2015 until later in 2018 if you don't want to. But if you decide to, you can attest to either stage 2 or stage 3 using 2014 and or 2015 edition technology.
So yes, you can have 2015 technology installed and working and still attest to stage 2. Not required to go to stage 3 just because you have a fully certified.
Right. So let's talk about quality reporting, because CMS had quite a few things laid out as, they're trying to give practices the option of how they report, but as time goes on, you're limited in your choices. So let's see where you are as of the beginning of the last quarter, where we are right now. First of all, you had 4 options. One was to do claims, one was to use the CMS web portal, one was to use data registry reporting, or one is to do what they call EHR vendor reporting, which is basically taking the information straight out of your reports out of your system and either having your vendor report or have you report. The reality is the first 2 the ways of reporting quality are no longer available unless you're doing claims for only 90 days. If you're only reporting quality for 90 days, because you have the option of doing 90 days or a full year this year, if you're only doing 90 days, you can still do your claims coding for your quality measures starting next week. But that if you haven't done it, you're running out of time to get that set up because you have to report on at least 50% of your Medicare patients. CMS web portal reporting is not an option anymore. You would have had to sign up for that by June 30th. So basically, you're looking at data registries and EHR vendors. And I just want to make sure you understand something because, again, this is something that we didn't understand, and I don't think anybody in the world understood. And CMS put out a beautiful FAQ. We sent them, I have to say, we bugged them to death. Like every week we're sending them questions to try to get explanations and have them think about it. And we got a really, really nice FAQ that talked about data registries and what it meant to report by data registries or EHR vendor. And the takeaway that I want to leave you with on data registry reporting is, should you decide to go with a data registry, and we have a slide, a couple slides away, that lists the link to all the data registries that are recognized by CMS, and you're welcome to go through that. But should you decide to do data registry, you have the most expanded option of how to report your quality, and you can report your technology numbers, and you can report your ACI all through the data registry. Or you can split that up. You can just do quality, whatever you want to do. There's a tremendous number of options using a data registry. But the most important message that I want to leave you with data registries is they have one option that is not available anywhere else, and that is to do your quality metric reporting as an attestation. So remember what you've been doing the past several years for meaningful use, and you just add, enter your numerator and denominator to report on a quality metric as part of meaningful use. Well, going ahead this year, the only way that you can do that type of quality reporting, where all you're doing is attesting to the figures that appear in your EHR, is to do that through a data registry. And they will set it up so that you go in and enter your numerator and denominator, whether you're doing individual or group reporting. And then that is what they send on to CMS. What you will have to do is keep your underlying reports. Right. Scott's all over the audit issue.
And the key to that with the data registries, to be able to attest to your numerator and denominator for a quality measure, is that your EHR must be certified on the Chapel site for that given measure.
Right, right, which is a little bit different than if you're drawing your information out through abstraction or QRDA extract or anything like that. The EHR vendor option is something you will want to check with your vendor. They call it the EHR vendor option because basically what you're doing is you are pulling a certain type of report called a QRDA. It's a quality, I can't even think of the QRDA, quality report data abstraction or something like that. And so it comes directly out of your EHR. So you do no auditing of it, you do no change or anything. It's just taking the report, uploading it to CMS, and getting your results. Now, depending on the vendor, some vendors will abstract that report for you, and some of them may even push it up into the CMS portal for you, but not all of them. A lot of them will give you the ability to actually just pull that report yourself. They're supposed to have that capability in the system, but not all of them seem to do it. But if your vendor is one of the ones that is doing that, you can go in and actually extract that report yourself and just send it to CMS through the CMS portal in January, February, or March when it is open. Or, as I said, depending on your vendor, some of them will include that type of reporting in their contract with you, and that way you won't have to worry about it at all. But the reality is you want to look at that and see if they're going to charge you a lot of money to do that or not. And if you're doing any type of quality reporting other than claims, you have to report on 50% of all your patients, whether they're Medicare, Medicaid, private pay, self-pay, whatever, 50% of all your patients. It is only claims where you send just Medicare. Okay, and here is the information that I said we'd give you. Here's the list of two types of registries. The first one are the general qualified data registries for submission, as I said, of the technology, old meaningful use measures, the quality measures, the clinical practice improvement can all be reported in this first group. The second group is more detailed information, and that really goes to the specialty societies are the ones that run the QRDA Level 1 qualified clinical data registries. And these are ones that are more linked to a certain group of patients than they are to your overall patient population. And so if you have providers who are especially active with a specialty society, or your practice is completely geared around, say, cardiac or urology or something, these are ones that you may well want to check what type of reporting options you have through that specialized registry, because in those cases, CMS will take measures that might not be generally recognized in the overall population, but are allowed to be reported for a specialty group. And here's just some other links that might be helpful to you if you are in need of specific assistance. As we said, you have QPP Info, which is Alterum, that is working with small practices. PTN also works with small practices, and HSAG, who is the support group that Medicare pays for within the state who can answer all kinds of quality reporting questions. But as we go along, what I want to do now is to have you think in terms of pulling all this together, because I think the thing that's been very difficult for practices this year is being bombarded with all this new reporting requirements, being bombarded with a huge amount of information on patient population and population health information, because all of a sudden we're going from zero 10 years ago in what we knew about the overall population to things that were just manually extracted, to now we've got, every year we're reporting on 10, 20 million patients. And so you're getting overwhelmed. So let's try to draw this together. You've got the MIPS reporting if you're going to do it this year. But part of that, and what we're trying to get you to focus in, not only for your practice, but for the state of Ohio, is these chronic conditions, especially of diabetes and hypertension, and the undiagnosed aspect. And hopefully this will help you when you're deciding what practice improvement activities you're going to track for your practice, because so much of what we're talking about from here on in is a recognized practice improvement activity, whether it's working with your pre-diabetes population, your diabetic population, whether you're setting up your own DPP program, which is what diabetes prevention is called. These are all high priority items for CMS and actually the state of Ohio also. So let's take just a real quick second and say, what is prediabetes? Because a lot of people don't really recognize this. It's not a term that's in our vocabulary as clinical practitioners yet. Hopefully it will be soon. The state has been working on this for a number of years with CDC to get people to think in terms of taking a step back from letting people become type 2 diabetics and then just going crazy in trying to provide chronic care management for them, and instead realizing that if you just worked with them a little bit sooner in the process, as they're younger, as they have the opportunity to change some of their lifestyle, that you can actually avoid type 2 diabetes. And what we're seeing, and as I said, we can all be very overwhelmed with statistics, but the next two slides, I have to say, bear with me, only because I think it's so telling. And I think you'll understand very quickly why Ohio has set the work with prediabetes as its number one, well, I shouldn't say number one healthcare priority, but certainly one of the top 2 or 3 priorities in the state in 2018 is to work with diabetes prevention. Right now in this country, there are 84 million Americans who have prediabetes, which is a third of the whole population. These are people that are not fully diabetic yet, but are showing to be at risk for diabetes. If nothing else changes in their lifestyle, they will become diabetic within the next 10 years. And of these, 23 million of these patients are 65 and older, but that means that there's 60 million patients that are younger than 65, where the chance of changing their history so they don't become diabetic and have these problems is much greater. So it's really worth spending a little bit of time. In Ohio, we're especially vulnerable to the question of what prediabetes is and how it's affecting our state, because in Ohio, for diabetes alone, we have 13.5% of the adult population, so over 1 million patients have diabetes, which puts us, as I recall, I think we're about 7th in the country on the percent of patients that have diabetes. And so many of these patients don't even recognize that they have diabetes yet. So it's really important to go to the screening aspect of what we're going to talk about. And the screening will help you to identify not only your prediabetes patients, the ones that you hopefully can make a difference with, but also for patients that are diabetic that may not have been diagnosed at all. The next few slides, we're not going to go through each one, but we put them in there because we thought you'd be interested in it. And this is, we've been working with the Health Department, Ohio Department of Health, for the past 3 years in a project to reach clinicians around the state about diabetes and hypertension and its management. And we now have 3 years worth of figures on patients coming out of the hospital, how many of them have diabetes and hypertension. And we're still, although we're seeing some small improvement in both areas, we are still fairly high. Ohio overall in 2016, the diabetes as a percent of total discharges was over 42%. And for hypertension, it is a scary 54%. So we really, when you're setting up your chronic care management programs, especially if you're in one of these new payment models that requires you to do some risk stratification of your patients and to basically identify high need patients and then follow up with them on their needs, consider your patients who are either diabetic or hypertensive or both, because this is going to be a significant change you can make in your population. Each of these charts has information by county, and so that may be something that you'll want to look up your own county. But on the prediabetes, there are different ways to identify it. But what, as I said, if you can do a very, very simple assessment early on, it will really help you identify your patients who are both pre-diabetic and diabetic. And so basically the CDC did a partnership with the YMCA over the past 5 or 6 years and has developed this whole program about handling prediabetes. Part of that was a very simplified, I call it elegant, because when you look at it, it really draws together every piece of information that you would need to know about whether this person is going to be a high-risk patient for either prediabetes or diabetes. And here's the form. It's generally agreed upon. It's the CDC and the American Diabetes Association have jointly with the AMA have put together this kind of very simplified form, which goes to some really easy questions, you know, your age, your sex, did you have gestational diabetes if you're a woman, do you have high blood pressure, do you have a family member who has diabetes, how active are you, and what is your weight? So as you can see, it'd take, what, maybe at the most 3 or 4 minutes to answer. You can either have the patient do it directly, or you can ask them the question and enter it. And then depending on the score, it will show exactly what the patient's risk is of developing diabetes and make a determination for you whether you should go ahead and order a glucose blood test or an A1C to find out if in fact they are diabetic or if they do fall into this prediabetes category. And because this is such a high priority, I found it a real interesting tale that CDC, as they did this study or pilot with the Y, and the results came back, this to me is just incredible. It showed that 60% of the patients who go through a diabetes prevention program, and my shorthand for what a diabetes prevention program is a health and wellness program. You know, working with you with your nutrition, working with you on your exercise, kind of doing group activities and, you know, very tailored, specific areas. And when the Office of Management and Budget, that is not known for being particularly friendly for spending money, saw these results and they recognized the billions and billions and billions of dollars that CMS spends every year on supporting people with diabetes, they were like, it was a no-brainer. And they have adopted this whole concept of working with pre-diabetic patients, scanning them, then following up with them. And CMS is going to pay for a bunch of this. It is in their new regulations, and it was such an important part of their new regulations. It is their #1 priority this year. They spent 200 pages talking about setting up diabetes prevention programs. So as part of this, they give you a code to use so that you can put this into your EHR. And Scott's going to show you in a second how you can then use this code to track the patients in your system. But the code that was set up is an ICD-10 code, and it's what they call an interim diagnosis code. So it's saying, we think this patient may be on their way to getting diabetes, but not quite there. So we don't want to code them as diabetic, but we want to identify them in our system so we can go back and work with them. So this code is R7303. It was just begun last fall, it's a year this coming Monday, but R7303 is the code that you want to use that will then kick off and track the ability for CMS to pay for this if it's a Medicare patient, but also give you the ability to track these patients within your system. And here, so you can just see how all the coding comes together with this new prediabetes assessment form. Here are all the areas that we looked at in the assessment form: your weight, your family history, history of high blood pressure. And this chart will show you exactly how to code this within your EHR so that this is then reflective of when you look at your problem list and you're drawing all the correct information, which again will help you to work with these particular patients. Once you have confirmed the fact that the patient has high risk, and high risk in the CDC lexicon means that in these prediabetes assessment forms, if you score 0 to 4, you're considered to be low risk. If you score 5 and above, you're considered to be at risk and should follow up with glucose or an A1C to find out what the patient's actual blood value is. And then if you need to, you run it on a regular basis to check and make sure that they have not become truly diabetic. So as I said, I'm just going to turn this back over to Scott here, but just to kind of fix in your mind what the concept of a DPP program is. It stands for Diabetes Prevention Program. It is a health and wellness lifestyle change program that either you can set up as part of, and CMS will pay you for your Medicare patients who go through it, or you can refer out to what are becoming numerous programs. We had started the year with only 30 sites doing DPP, and I think we're up, if not over 40. We're really moving along, and we just talked to ODH today, and I believe that there are quite a few more in the pipeline. So it's something that is recognized, and it does not have to be limited to your Medicare patients. Please don't misunderstand me, because as we said, there are a good 60 million patients that aren't Medicare age that fall into this category. So you want to work with them. And the goal here is to have the patient lose 5 to 7% of their body weight, which then brings down their hypertension and decreases significantly their risk of getting diabetes. And so with that, I'm going to turn it over to Scott to talk about the technical side of how to get this done.
So with respect to prediabetes, diabetes, undiagnosed diabetes or hypertension, the best tool you have out there is your EHR. Everyone has an EHR. Everybody had to get them for meaningful use.
Well, everyone that's working.
Well, yeah, there we go.
It's working, but yeah.
But in my opinion, the data in there is probably the most underutilized tool for public health. The reason being is many folks, they got their EHR set up, they got the workflows, done, they started documenting, they got the bills coming in, going out and money coming in. They just haven't had time to go back and look at their reporting tools, look at how they can flag patients, look at the CVS rules that they can present. And that's a little bit about what we're going to talk about now. So first, we're going to talk about a patient registry list to identify those undiagnosed prediabetics or undiagnosed diabetic patients. I use the term patient registry list. Some EHRs call it a registry, some call it a patient list, some call it an ad hoc report. So we try to use terminology that's all inclusive. So if you want to identify the pre-diabetic patients, for one, you could just do a report looking for that new pre-diabetic code, problem code.
R7303.
Right. And if you don't have that, then you can always fall back to the fasting glucose between 100 and 125, the random glucose between 140, 199, and so on. Run a report that is looking for patients who do not have prediabetes on the problem list, but have one of these lab results within that range, and you can call that person a pre-diabetic. Based on those alone, send them over to your DPP, get paid for those patients. Now, to identify an undiagnosed diabetic patient, those test results are a little bit higher. Also, you can use that CDC or the ADA assessment form that Cathy showed you a few slides ago. If they come at a score of 5 or higher, call them a pre-diabetic, code them pre-diabetes, get them over to the diabetic prevention program. Also, many organizations are kind of undertaking a program to focus, at least in the short term, on pre-diabetic patients, again, because of the high rate of patients who do not then transition over to diabetes. So they're creating chart alerts. They're going to run these reports. These reports in most EHR act as a driver to other functionality, like creating a chart alert. So they're going to create a chart alert for all those patients that they've recently identified as pre-diabetic, so that they know to recheck their glucose or get them over to the DPP, or maybe just follow up to get them in to see if they are truly an undiagnosed diabetic patient. Also, use these same lists, these same reports that you've developed to drive your messaging via the patient portal. Send a message out for Diabetes Awareness Month, even to your pre-diabetic patients. Maybe you're going to send just kind of ongoing little tidbits of information to keep that patient engaged between visits. Now let's talk, we're going to transition now over to your hypertensive patients and undiagnosed hypertensive patients. The way that the Million Hearts program and other programs are looking at an undiagnosed hypertensive is a patient who has 140 over 90 BP at least twice in a rolling year. If they do meet that condition and they do not have hypertension on their problem list, you probably need to get them in and consider them a hypertensive, do some additional testing, and see if in fact they should be treated for that condition. Also, it's very important when you generate your lists of these patients, race plays a big factor in hypertension. There are some races that are more likely to have hypertension or see what some folks will classify as pre-hypertension progress to hypertension. It's real simple to generate a list for patients that are overdue for the regular appointment that have hypertensive. Get in there, run that report, get those patients in the office, get them seen. Not only is it some additional income revenue for the practice, but it's just good clinical practice to get your hypertensives in the office at least every 90 days, if not just twice a year. Now, there's a lot of talk around the patient submission of self-monitored blood pressure readings. Some folks will tell you that there's clinical relevance. Some people will tell you that there's no clinical relevance in that. I think even in the cases where they've got a really bad blood pressure cuff, maybe they don't know how to use it, if they're seeing, day after day after day high blood pressure, there's probably still some clinical relevance. Now the question is, how do you get this information? Sure, they can bring it in during the visit, scribble down on a notepad, but your patient portal, the secure messaging feature of your patient portal, is a great way to keep that patient engaged, get them to submit that information that you can then just attach right to the patient chart. So don't overlook that functionality. Yeah, it's pretty basic, but it works. There are some of the EHR vendors are expanding the functionality within their portal so you can get more structured data. It's going to be a great thing, but right now we're kind of looking at secure messaging. And again, use these hypertension lists, these reports that you're creating to drive other functions. Send those reminders to the patients. Send them a message about Hypertension Awareness Month. Just little educational information between visits, again, to keep them engaged. Now let's talk about undiagnosed hypertensive patients. There's a number of ways you can pull reports to look for those patients, but the first thing I will tell you is first do an audit of your chart. If you just go in, you create a report to say, okay, I want a report of, I'm going to call my undiagnosed hypertensive patients everybody that has 2 readings of 140/90 or no blood pressure readings. Well, that no blood pressure readings can get you in trouble. Do an audit to make sure that your staff, your care team are entering the blood pressure information correctly in the system and that it's recorded as discrete data. Because if not, you're going to get a lot of false positives. And then maybe you want to look at not just the 140/90, maybe you want to back that down to get those people that are, above the 120/90, but below 120/80, but below 140/90. That maybe you want to call that pre-hypertension if that's really a thing, but those are the patients you want to focus on so they don't in fact progress to a true hypertensive patient. And again, it's all about using the data that you've been entering in your EHR for the last 3 years. I strongly recommend you spend the time to learn your Adhoc reporting tool. Some EHRs just call it the reporting tool or have some other name for it. Whatever they call it, take the time to learn how to use that system. This is an example. We're looking for undiagnosed hypertension. And this is an example right out of Allscripts Pro. Allscripts Pro has a really good reporting tool. We're going to focus on the very bottom pane here where it says return all patients based on the segment active patients ages 18 to 75. So more or less what it's doing is saying, okay, go do a little pre-query, have all my active patients seen in the last 2 years that are between the ages of 18 and 75. And then it's saying, okay, now I want to, out of those active patients, I want to narrow it down to patients who in the last year, 365 days back from today, that have at least one blood pressure reading that's 140/90. Real basic. We also should have added in this report that they do not have hypertension on their problem list. So that way it's going to look for those undiagnosed hypertension. You can add multiple factors to most of the report, but the key message is learn your reporting tool. Learn how to use reports within your system. Learn how these reports then attach to other activities within your system. You'll see on the screen up towards the top, there's a checkbox called Preventative Health Reminder. Well, what you do is you check that box when you run this report. It then pulls up a portal function that allows you to send a reminder to all those patients that are returned on the list of patients that meet these criteria. Now, CDS settings or CDS rules, clinical decision support rules. Back in the day when we first, everybody was buying their EHR, everyone thought of a CDS rule as that intrusive pop-up. Hey, you forgot to enter something. By all means, that is a CDS rule, but now folks have expanded the definition. It also includes any alert or any reminder that's focused on not just the providers, but any member of the care team, including your reception folks that are working the front desk. Sometimes this can include your patients. Of course, it can include your clinical guidelines or your care guidelines, your condition or problem-specific order sets, other reports, just anything that drives workflow or protocol around a certain condition that reinforces what your care team should be doing that's best practice for a given condition really is considered a CDS rule with today's definition. This is a great example. Within Greenway, you first develop your report. We developed a potential pre-diabetic report. And then we said, okay, now that we have this report where we don't really know if these folks are truly pre-diabetic, so we're going to call them potential pre-diabetic. we took that report, and with 2 checks on the report running through, I think 3 more clicks, we now have a chart alert for this patient. Now, don't go overboard with your chart alerts. If you get too many chart alerts, they then become meaningless. This is kind of teetering right on the almost meaningless number of alerts. But when you access it, you pull up this patient's chart, this screen pops right in front of you, so you can see everything that's either needed or that's identified about the patient that you felt that was critical enough to stop the workflow and put it right out in front of the care team.
So let's kind of recap real quickly, and then we'll move into questions. Is this year for your reporting, make a decision about how much you want to report. Even if you are doing minimal reporting this year, consider setting up a procedure that you use to screen your patients as part of a chronic care management or high-risk patient management program. Part of this can be your prediabetes assessment form, very short, as we said, takes less than 3 minutes to fill it out, and then use that to help risk stratify your patients as part of a chronic care management program, because you can use prediabetes. There's nothing in the MIPS regulations that say you can't use prediabetes as part of your chronic care management program. If you need to, think about referring these patients to a diabetes prevention program, or if you're really interested in it now that Medicare's got on the bandwagon and you want to set one up, go to the CDC and figure out what it would take to set one up. But the bottom line is our Ohio Department of Health has tons and tons and tons of information about hypertension management, about diabetes management, and about prediabetes. And so your best bet is probably to contact the ODH, and we can give you their information, and you can contact them. They'd be more than willing to help you either get education materials together or to set up your own prevention program.
And many of the local health departments now have information around healthy eating choices.
Yeah, maybe the local health departments too, absolutely.
And also, the most important thing that I think to remember if you're considering setting up a diabetes prevention program is that program does not need to be led by a nurse practitioner or a physician. There's a range of folks that can be a nutritionist. It can be various folks that don't have those designations that can lead the program and still get paid for that by Medicare.
Correct, and can certainly do the assessment.
Absolutely.
So just be creative with your programs, recognize what a benefit it's going to be, and it'll help you easily work with a targeted group of your patient population.
And as you're working through the sometimes complex MIPS program, if you have questions, by all means, Cathy and I are here to help. You probably already have our contact info. If not, it's here. It's available. When those rules are finalized, we'll be reading those 3,000 plus pages of regulations and doing a series of webinars as we always do.
Okay, and we will send out to you as part of this handout contact information for the Ohio Department of Health if you'd like to follow up on any of this.